Hello, everyone. This is Sherry with the CGH Health Foundation, and welcome to our broadcast. Today's program is one of our Growing Healthier educational series where we feature important health topics. And March is Colorectal Cancer Awareness Month. So today, Dr. Bird is going to be talking to Dr. Jorge Monteagudo about digestive health issues, screenings, what you can do to prevent digestive diseases, etc. Next month's program, we're going to be talking about your personal health information and how CGH protects that. We don't have the date definitely finalized, so please watch for our announcements on our Facebook page about that. And before I turn it over to Dr. Bird to talk to Dr. Monty, I want to give you some exciting news. The CGH Health Foundation's campaign for the past year has focused on dementia and dementia awareness and programs. And one of the things that we really wanted to do was to establish a dementia navigator person. And so this person would be responsible, if a person has a diagnosis of dementia, for helping them to navigate that whole process from diagnosis and what services are available, and answering questions between the doctor and the patient, and helping them to develop a care plan, and all of that, because that's a big, a problem for a family to start to encompass. So we're very happy to announce that we have hired Beth Sturck as our dementia navigator, and Beth starts on Monday. That's March 27th. And so she'll be there for our patients and their families. And Beth has over 30 years of experience in working with senior issues. So she's a very familiar face, I'm sure, to some of you. So starting on Monday, Beth will be available to our patients. And now I will turn it back to Dr. Bird, and he can start his interview.
Thank you, Sherry. Appreciate it. Welcome, everyone. Excuse me. This is Dr. Bill Bird, Chief Medical Officer here at CGH Medical Center. And today, as Sherry alluded to, we're going to be talking all things GI with Dr. Monteagudo. So, Dr. Monty, let's get you on the screen. Hello there.
Hello.
How we doing?
Good.
You ready to take on a few GI questions?
Let's start. Let's get going.
All right. Here goes. I'm going to start with this is screening colonoscopy question. What are the latest recommendations on that, George, in terms of what that should look like?
Well, that's a very good question. Number one, it has changed a little bit in the last few years. We used to say that screening for colon cancer would begin at the age of 50, but nowadays that's has changed. Now we try to start a little bit earlier, at the age of 45. The reason behind that, there's been a shift since 1995 in terms of the age of presentation of colon cancer. So it's a little bit more common presentation now at a younger age. So instead of having 50, we begin at 45, and that's for the general population. Now, okay. Also taking in consideration is the genetics of a person. In other words, if they have any family members, first-degree relative of colon cancer, colon polyps, if there's a strong family history of any multiple cancers, then we have a tendency to try to identify those individuals even at high risk, and those individuals sometimes have to be screened even at an earlier age. For the most part, individuals that don't have a family history, they're just the average person, we begin at the age of 45. And then that's the first colonoscopy. And after that colonoscopy, we can streamline it and we look at the genetics behind the individual. And if a person we find a polyp, a certain type of polyp, then we start doing the colonoscopies, repeat them every 5 years. If they don't, then we wait 10 years. And that hasn't changed very much. And occasionally we have to do colonoscopies even within the 5 years, less than 5 years, but those are very selected patients, individuals that we find something suspicious.
You know what comes to my mind, George, about this is like, why has it changed from 50 to 45? What's happened that has made?
Well, there has been a 20% increase in colon cancer detection in younger population, and cancer of the rectum is also increasing. And nobody knows for sure why that is, why there has been a shift. But there has been a definite shift, and we have to take into account that phenomena. And so most institutions are recommending colonoscopy early. The cause of that is not very well understood.
Yeah. You know, I've kind of wondered, like, if it kind of goes lockstep with the incidence of people being overweight or obese in our society has continued to go up over the decades. And I know that there are some studies about being overweight and increased risks of certain things besides just heart disease. And I kind of wonder about that a little bit sometimes.
Yeah, that's true for adenocarcinomas of the colon. The other thing is the issue of rectal cancers, and that's more HPV related. It's another phenomena that's happening. So there, if you really look at it,
that's a different animal. Yeah.
Exactly. So we're looking at adenocarcinoma, which is actually increasing in the left side in young people, and then you look at individuals that are having rectal cancer of the anal verge or cancer in the beginning there, which is a different kind. It's a squamous.
Yeah.
And that is more related to HPV type of encounters.
Yeah. Now, I know that one of the things that you and I have talked about, Dr. Monte, is that there's a lot more people that could have screening colonoscopies than do have them done. And one of the things that I have heard from patients over the years is that they are concerned about the safety of having a colonoscopy. Can you kind of speak to that for the folks who are listening?
That's a very good question. And I'll tell you, first of all, the issue is the safety is related to many, many issues. And one is patient selection. Now, in this world, and the pandemic has shown for coronavirus, that there's a group of individuals that are kind of hardcore. They don't accept certain things. And that percentage is not small. Actually, that percentage is 30 to 40%. And we've known that even before, even the coronavirus issue. People that are told by their physicians or other practitioners that they need to have a colonoscopy, and they refuse for many reasons. And we've been trying to crack that for a long time because we would really like to convince people that this is a worthwhile endeavor, but sometimes it's very hard. Now, when it comes to the safety, this is what I tell people. Number one is patient selection. The idea behind a colonoscopy is very simple. We take a little flexible tube that has a camera and we go 6 feet into the colon and go around and come out. Well, the reality is that it's not easy to go from one end to the other. It's and it requires somebody with a lot of expertise to do that. Now, if you look at, and that has been looked at, a number of years of experience that you have to in successfully completing a good safe colonoscopy. And it takes at least 2 to 3 years of an individual doing it on a daily basis to be really good at doing a colonoscopy from left to right. The other thing is patient selection, or people that are high risk of having a complication. And those you can identify them primarily because of the configuration of the colon, that there's a problem. It's a lot of twists and turns, or the age of the individual. You have to realize that as we get older, and I show this to a lot of people in my office, elderly people that come in and they'll say, I need a colonoscopy because I had one in the past.
Yeah.
And the question is, well, can I have one when I'm, say, 80? And the answer is, it depends, but we try as the years go by not to do them because the risk of having a complication increases because the colon lining becomes very thin as you get very, very old. And you have to realize that that's when you start looking at a potential risk. So the procedure is very, very safe, somebody who's under the age of 65 to 70, but it starts getting a little bit more of a concern as you get older. And so you look at all the parameters. You look at the patient's experience in the past, if there's a problem in the anatomy that we're dealing with, and that's determined by the doctor. And then, of course, you look at the doctor and say, how many of these things have you done over time? Like riding a bicycle or playing the piano or typing. The more you do it, the better you become at it. So you have to look at the person's doing it. You have to looking at the risk of the patient themselves. And it's a very safe procedure if we take that into consideration.
Very good. Okay. Got a nice comment there from Melissa. Thanks, Melissa. Someone saying hi to Dr. Monty. All right. So next question. I'm gonna transition to something else, to hepatitis C. Okay. It's for some of you may have noticed that that's been in the news recently, and it's actually kind of like the government wants to try to eradicate it. Dr. Monty, can you kind of talk about? I'm gonna throw out several questions at once at you. Talk about hepatitis C in terms of what causes it, what health problems untreated hepatitis C can cause, who should be screened, and the effectiveness of the treatment if someone is found to have hepatitis C. I give all those questions to you.
Well, I'll tell you, that is a topic I can spend a whole hour talking to you about. Probably more than that. But let's begin historically. The problem with hepatitis C is caused by a virus. And these are called, hepatotropic viruses. Viruses that can stay and linger in a certain organ. Hello?
You're good.
I can't see anything, but so I can't see the screen. Hopefully you can hear me.
Oh, okay. Yeah, we can see you. And I think if you just kind of wiggle your mouse, it might pop back up.
Okay. Okay, well. That's a problem there because it doesn't do what it's supposed to do.
I'm supposed to. All right. So Dr. Monty he's getting it together here. He's getting re-technical, getting up to tech and everything with that. I'm going to have our folks, they're going to call the DHC where Dr. Monty works and have them pop over across the hallway and get him set up here in just a second. So I think what I'm going to do while we're waiting for Dr. Monty is we're going to go through some of the updates that we normally would have given towards the end of the broadcast now. So I'm going to have Rebecca. There we go. Thank you. So first of all, we have a nursing open house that's happening March 28th for new graduates. And so it's an opportunity to learn about opportunities here. It's an opportunity to learn about opportunities here at CGH. So I would encourage those who are in that category to come. And if you know someone who's going to be graduating from a nursing program, please let them know about this opportunity. Doctor's Day. So Doctor's Day is March 30th. So just want to give a shout out to our physicians here at CGH who do just a marvelous job, and thank you to them. We will celebrate them that day, but I want you to know about that. Blood drive, April 6th. So this is going to be 2600 North Locust Sterling. So actually it's not typically it's been at the hospital in our auditorium, but that is under construction. So this is actually going to be on the road going north of town on Locust. So you get pretty close to getting that intersection where there's Kroger's and some car dealership type of places. Keep going another 100 or 200 yards on your right, and that's where that facility is. It's where we have our pediatric rehab for patients who have gone to there. So having that. Yes, and we have a student volunteer program we want people to be aware of, and those are the dates, June 5th through August. And high school or entering high school, and it counts towards SVCC impact program. So those of you who are getting community service hours to be able to have your community college education paid for, this fits within that program. So send your application. We have a few spots open, and we'd like to have a few of you be part of our volunteer program. And then this says April 13th about having Chris Lawson and how CGH protects your health information. That's a big enough topic. We wanted to make sure we took some time to let folks know about how we go about doing that. We're not going to do it April 13th. Actually, on the 13th, and we've kind of moved things around. We're going to have nephrologist come and talk with me about hypertension and the treatment of that. And we're going to have Chris some other day in April. So more to come in terms of the timing of having Chris available. So that's what I have in terms of those shout outs. And I'm wondering where we're at in terms of Dr. Monte. I'm told to hold on. So Dr. Monte will be here soon. I'm going to pivot and talk briefly about some other things going on here at the hospital, just so you're aware of some new services that we've started. One of the new services that we started is something called teledermatology. So now you can come to our facility, and we actually have a dermatologist who can see patients remotely. We know that our wait times for dermatology have been long, and Dr. Steves recently left CGH. And so actually we're backfilling his capacity with a teledermatologist. And that dermatologist is going to be seeing patients actually 5 days a week. So we really think that that's going to help in terms of our access for dermatology services. Now, that dermatologist is a good fit if you have a rash or psoriasis or acne or those type of things. Obviously, we're trying to get the patients who might need a biopsy into our other dermatology providers. So we're working that through. We're happy about having that service. Also, from a standpoint of neurology, we know that we've had some access issues there in terms of wait times with Dr. Dela Cruz and Dr. Joseph. So for the past few months, we've had a teleneurologist who is seeing patients in the clinic. Once again, you have to come to the clinic. A nurse is in there with the appointment with that doctor. We've had really good feedback in terms of patients being seen by Dr. Nguyen in that clinic. Last I heard, the wait time to see the teledermatologist is much shorter. It's in that 1 to 2 week window. As with the dermatology, there are certain neurological symptoms and conditions that are a better fit for a dermatologist on a remote kind of situation. And I think we're doing a pretty good job of getting those patients in. So for example, if you have a dementia type of issue, if you have issues with seizures, those type of things are a good fit for a remote neurologist. Okay, I think we have Dr. Monte back. There he is.
In conclusion, no.
All right, well, welcome back, Dr. Monte.
So I was about to say
you were talking about hepatitis C, so I'll let you keep going on hepatitis C.
All right, so hepatitis C. Hepatitis C is a virus that sticks to the liver, okay? And it was identified for the first time in 1989. Now, the problem with that virus that over 20 to 30 years, if you have that stuck in your liver, it can create scar tissue in the liver, and that's called cirrhosis. And that's a bad thing to have, but it takes a long time. Now, the other issue is what else can happen? Well, over time, that virus, if it stays there for many, many years, 20, 30 years, it can give a person cancer of the liver, a hepatoma. So it destroys the liver slowly over time. And number two, it can give you cancer. Now, in 1989, we identified the virus. The treatment began in 1991. And at that time, it took 3 years of shots every week, 3 times a week, with a cure rate, getting rid of the virus 15% of the time, 1-5.
Oh.
Nowadays, in the year 2000, I'll tell you, so about 10 years after the initial treatment, the cure rate was 50% over a year's time of once a week shots. Nowadays, we can cure you 98% of the time, okay, with the treatment, for most of the treatment to be as little as 8 weeks, taking pills that hardly give you any side effects. So the reason behind the impetus to try to get rid of this virus is that anybody who has it, the clock is ticking. Yes, it ticks very slowly, and you have many years, but it would be nice if we can get to you and identify you as having hepatitis C and give you a treatment that is 98% effective, easily to get rid of the virus altogether. And if you do, the incidence of just destruction of the liver is minimized, or it completely goes away, it stops. And the incidence of cancer of the liver decreases considerably. So it would be nice if we can identify those individuals and identify the fact that they have a virus and allow them to have this cure rate, which is almost 100%.
Yeah.
Now, the question is, how do you get the virus to begin with, is the issue. Well, in the number one way of getting that is getting it somehow in your bloodstream. Now, years ago, it was identified in individuals that somehow gave themselves, shot illicit drugs in their veins, that they could be a candidate for having hepatitis C, even if you do it once in your life. So that was like a big, gigantic group of people that became infected with that, 20, 30 years ago. Now, before 1989, since we didn't know the existence of that virus, in essence, the blood bank was contaminated to some degree. Okay. So that individuals could, if they had a blood transfusion before 1989, they could develop that virus stuck in their liver because of that transfusion. Okay. So that was another big group.
Okay.
There's a certain percentage of people and nobody knows why they ended up with hepatitis C, but it is believed that that's a screenable disease. In other words, individuals that have no symptoms, sometimes they maybe had, anybody that was alive in 1989 before that, who had any kind of experience with, drug use or anything at all. Some people want to just screen the whole generation to identify this virus, like eventually will give them, horrible, diseases in the future. Take 20 to 30 years. That's something similar to what happened with hepatitis B. The difference between hepatitis B and C is that B, there's a phenomenal vaccine that works great. Okay, so that prevents an individual getting hepatitis B to begin with. And hepatitis C, we don't have a vaccine, but we have antiviral agents that can cure you 98% of the time. Okay, that's the difference.
Yep. Yeah, very good. Okay. All right, I want to talk about another problem that can lead to liver failure, and that is fatty liver disease. So let me just kind of, what I have here is it's kind of become one of the main causes of cirrhosis and liver failure, causing need for a transplant here in the U.S. So if you would you kind of talk about what that condition is, fatty liver disease? How would someone know if they were having this problem before they get to the point of getting like scarring and cirrhosis of their liver? Could you kind of talk about that some, Dr. Monte?
Okay, that's a big question, and that's there's a lot of issues here. It turns out that years ago, say 40 years ago, when we were talking about fatty liver disease, I mean fat in the liver, there was a specific name that we used to use, and that was called steatosis. And you have to realize that when we gain weight, usually the liver ends up having deposits of fat, just like any other organ in the body. Okay. Now, back then, it was believed that fat in the liver was just extra fat, and it didn't do anything to you. But it became everybody became aware that there is a subgroup of people. So 25% of people that have fat in the liver, they don't just have fat in the liver. The fat cells become toxic to the liver cells. The fat cells create an inflammatory response, and that's called steatohepatitis. In other words, out of all the people that have fat in the liver, a quarter of them will have an inflammatory response from it. Okay. 75% will not. Now, the problem with that is the pandemic of obesity. In Western countries, we see that people are 30, 40% of the population, sometimes even 50% of the population in some states have fat. They're obese. And that comes across, all those individuals will have fat in the liver. So the question is, does that person have just fatty liver, simple fatty liver that's not going to do anything to them, or are they going to have fatty hepatitis? The way to find out is to look at your liver functions, which is a blood test, to see if there's any evidence of inflammation. The other way, imaging studies, ultrasounds can show fat in the liver. And another way is to have a CAT scan or MRI scan that will show fatty liver. Now, there a lot of times you see that the CAT scan will come back, and the results of these tests will come back as everything is okay except there's fatty liver. So then the doctor says, okay, you got fatty liver. Then the patient goes, oh my God, what's going on? You have to realize that if I, as a doctor, tell you that you have fatty liver, our concern is that how are we going to get that fat out of there? Because you have many, many years to get it out of there, but you don't want to be the 25% that develops a steatohepatitis. And the only way to get rid of that fat is to control your weight. And the first place that you lose weight is your liver. So if a person goes on a diet, they exercise more, they eat better, they have less, they don't gain weight, and they start losing weight, the first area that fat disappears from is the liver. And that is a very important thing because that is the cure of it. Now, if you think it through, this is a gigantic problem, especially in young people. If you have an 18-year-old, a 15-year-old that is obese, a child that's obese, okay, and you know that that person in 30 years is going to have 25% of those individuals will have advanced liver disease. You realize that if you have an obese child at 15 or 18, it has a very high probability in their, and when they're in their early 40s or 50s that they're going to have advanced liver disease. So we have all that time to identify them, try to see that they don't develop the fatty liver inflammation, and try to get rid of that potential problem that's going to be around in the year 2050, 2040, in the future, that is going to be a main cause of advanced liver disease in a population, other than, let's say, hepatitis C or alcohol-induced.
Yeah. Good. Let's transfer. Let's kind of go talk a little bit about alcohol. In some ways, it's the same concept. Thank you for all those comments, everyone who's sending out here as we're talking. As far as alcohol usage goes, it's the same question that comes to my mind, Dr. Monte, is, a lot of us have a drink here and there. How do you know if you're one of those folks that it's causing problems with your liver? You're smiling.
Another good question, and the answer is this. Now, you and I know people over the years that drink like fish, alcohol. And you say, how come these people don't get cirrhosis? Yet you and I say young people have developed cirrhosis from alcohol. Again, a heavy drinker, there's a chance that 20% of those individuals will develop cirrhosis. 80% of a heavy drinker will not. Okay. Yet you and I see the cirrhotics because those are the ones that end up in a hospital. But you do see those individuals at times that drink. I mean, I used to work with a guy when I was in high school that drank 6 quarts of beer from 4 o'clock in the afternoon, 11 o'clock at night while at work. And the guy drove and he worked the register and all that. Those are heavy alcohol, drinkers, yet they appear to be okay. Now, 20% is a large percentage of people. So yes, in some individuals, the livers are definitely more susceptible, to ending up getting alcohol-induced cirrhosis, and that's true. And it's also true that size matters in terms of liver disease from alcohol. If you have a big individual has a big liver, that person can metabolize alcohol a lot better than an individual has a little liver. So it is easier for a woman, let's say, to become cirrhotic than a male in the same amount of alcohol they drink, because sheer size of the liver allows it to metabolize one individual better than the other.
Okay.
So it does make, so the biggest thing with that is to try to control the intake of alcohol.
Yeah.
As much as possible.
Yeah, and so I'm guessing the same type of things, though, in terms of trying to explore if you might have that would be your liver enzymes, some type of scanning to see if you have any evidence of cirrhosis and those type of
that
things.
Is correct. And what you look, nowadays we have a thing called a fibroscan, which is it's like an ultrasound that sends a sound wave, but it bounces differently if there's scar tissue versus liver tissue. So it's a non-invasive way. You go ahead and it's like an ultrasound, and it sends you a signal to see how much scar tissue you have. Yeah. And that's a progressive thing. So fibroscans are good, liver functions are good. Um, Scans, if you look at density of fat, it is easier to see when you even if you drink alcohol or you have a fatty liver, there's a density change in the CAT scan that can tell you easily if you have a fatty liver or you have evidence of fatty liver from alcohol. And that's another form of identifying individuals early.
Yeah, good. Okay, I want to transition just a couple more questions, and this is more about just bowel function. So I want to go on both ends of the spectrum. I want to start with constipation. A lot of folks have constipation. What are your typical recommendations for folks who do have issues with constipation?
Well, there are different forms of constipation. The most common form of constipation is almost by history. Somebody tells you, and it's also how you define constipation, because that's another issue. Most people define constipation as frequency. They tell you I had a bowel movement today, but I won't have one for 10 days or 3 days or 4 days. Frequency. Some of us cheat and we do an x-ray and we can see the amount of stool in the colon. So obviously the average person doesn't have that. So content, the amount. There's a group of individuals that have what's called chronic idiopathic constipation. It's quite common. 10% of the population has it. Those individuals were born with a colon that is kind of a lazy colon. It's intact. There's nothing wrong with it. It's not diseased, but it doesn't move as fast. Okay. So the analogy, for example, is the heart. The heart goes, you can have somebody has a heart rate of 40 and it's considered normal. You can have a heart rate of 100. Okay, it's considered normal. The colon is a muscle, and it moves in a certain rate. If your colon doesn't move as fast, okay, you have to think of the job of the colon. The job of the colon is to get water out. So if everything stays in there and for a long time because it doesn't move very much, then the water gets extracted, and by the time it goes from right to left, by the time it gets to the left, it's like concrete balls in there. So it's very hard to expel. And those individuals, if you think about it, if you're going to fix that problem, what you would do is you would tell the colon, can you move a little faster? Okay?
Right.
And how do we do that? Well, the way it came about is laxatives. So years ago, your grandmother or great-grandmother noticed that a herbal thing, that they took some herbal things like Seneca or Cascara, that it would make the colon move faster, go from one end to the other, so that it worked. That's it. It made it move faster. Unfortunately, over time, if you use those agents, those agents slows down the colon over 3 to 4 years. And those stimulant laxatives cannot be used on a chronic basis. Okay. So if you cannot use the stimulant to say, go move faster to fix the problem, another way you can do is tell the colon, can you not absorb all the water out of there, please? Okay. And how does it do that? That's called an osmotic agent. And that's a laxative that has to be present in the colon so that the water cannot be extracted out. And that agent, historically, the first one was magnesium. So that's why MAC citrate, milk of magnesia. The ion in the colon has to stay in solution, so it doesn't allow the water to get extracted completely. So those are the first laxatives that are considered safe. Then they found that an agent, polyethylene glycol, which is Miralax, works the same way, but it doesn't have any taste. And that came out of the pediatric literature. Little kids don't want to take something that tastes funky.
I don't want to either, really.
Polyethylene glycol, which is in solution, it doesn't have any taste. And you give that, you give that to a kid, who's constipated by, a formula. And the idea behind that, it is very safe. You can use it for 80 years if you want to, and it doesn't damage the colon. And those are called osmotic agents. Okay. So what you try to do is, if your person has constipation, you try the simple things first. They're osmotic. Okay. And lactulose is another one. Granulac is another one. There's a different osmotic agents so that that phenomena of not allowing the colon to suck up all the water is considered. Right? You don't want the colon to absorb all the water. And then, of course, we have more other things that have developed over time that more reasonable, like pills that can take, and those are the third line. And those are like lenses and a variety of other agents that we have, and they require a workup. And the issue with those, primarily, the biggest problem that I see is that insurance companies, they want you to try the other agents first before you get to some of the other ones. You have to sort of work with them to try to find a safe agent that resolves that. And that's constipation.
Good. Thank you. Very good explanation. Thanks. And so the last question is the other direction, and that is when your colon doesn't absorb much of the fluid and you have issues with diarrhea. So how do you advise patients who have this problem, and when is it time for someone with diarrhea to see someone like yourself?
Well, that's another very good question. And that has to do with how long you've had the problem. Okay. So a person goes to another country and they have diarrhea, and they didn't have any problems with diarrhea until they went to another country, you start thinking of infectious diarrhea. Okay. There used to be in the old days the concept of somebody who had blood in the stool, diarrhea, bloody stools or watery diarrhea, and they had a fever. In those individuals, those are very sick individuals, and those are the times that we would think, things like typhoid and cholera and a variety of other agents. Now, we don't see that in the United States a lot, but we do see other agents that can cause diarrhea, like we're going to talk about it in a minute. C. diff, which is one of the common things that you see in the U.S. So you can have a category of infectious diarrhea. You can have a category of non-infectious diarrhea. And the question is it an acute event? Did it just started happening? Or is it something that's been going on for several months? Now, it is recommended if a person doesn't have a fever, doesn't have horrible cramps, doesn't have blood in their stool, they just have watery diarrhea, and it just began, something that just began in the last few days, you don't really need a lot of testing. You need to make sure you stay hydrated. Okay, so we push fluids, and that is a treatment of that. Now, if a person has a diarrhea for more than 2 weeks, or they have blood, or they have pus, or they have fever, then you have to see somebody, because then we have to see if we can identify the cause of the agent, if it's an infectious agent, or if it's a chronic non-infectious agent. And sometimes you can find it. You do a culture for the stool, and you see that it comes out. Now we're going to have a problem here again.
You're good. We can see you. You're fine.
Okay. So the issue where the person is going to have an infectious cause like C. diff or Shigella, Salmonella, Campylobacter. Those are the common ones you see in the United States, and those can be treated accordingly. And if all the cultures are negative and we don't see anything, then that's an indication to do at least a flexible sigmoidoscopy. Look at the colon to see if we can see inflammation, redness, or the cause of a chronic colitis that can lead to something like ulcerative colitis or Crohn's disease. So you have to look at the clinical presentation and how sickly the person is. If you're very, very sick, then we move a lot quicker.
Yeah.
Okay. So that is more or less the way you advance it. Now, the biggest problem that we have right now is C. diff, which is a bacteria that has been present for a long, long time, but it has become very insensitive. Can you still hear me?
Yep, I can hear you fine.
Okay. It has become insensitive to antibiotics, and then that creates another problem of how to get rid of the C. diff, and that requires a certain type of antibiotic, a certain way to approach it, so that we can try to. And the reason behind that diarrhea is that we lose the ability to fight. Our own body fights the C. diff, and if we alter the antibiotics, if we alter the flora with in certain ways, which is the most common way, some antibiotics or something else, then it creates a problem that C. diff takes over, and we have to sort of correct that problem. So we have to look at the type of diarrhea the person has to, really able to treat it. But most individuals that have acute diarrhea with no blood, no evidence of pus, and no evidence of fever or elevated white count, in other words, we're not looking for somebody who has a dysentery. Can you still hear me? Or?
Yep.
Yeah.
I have one last question that one of our viewers sent to us for you, Dr. Monte. In terms of C. diff, are there any long-term complications of C. diff?
Yeah, I mean, the problem with C. diff is if you can lose a lot of volume, so you can become really dehydrated. So it's something that takes weeks to get rid of, so we have to keep an eye on that. Then the other issue is if the C. diff gets embedded really in the colon, and that is what they call C. diff induced colitis. And then that depends on the injury of the colon. Sometimes the colon can be so injured that it just gets dilated and it doesn't work and it starts leaking, so that a person can lose a colon because they can get very, very sick from it. So those, individuals with C. diff, we have to treat them in a certain way. We have to keep an eye on them until they can finally get rid of it. Okay. Most individuals can get rid of it without any problem.
Yeah, very good. Okay, well, Dr. Monte, I appreciate your time. Very good. Very good to have you here. I was going to just one more reminder, everybody. We started this question out when we started the show. The 45 years of age is the new 50 in terms of getting screened for colon cancer. And this is Colorectal Cancer Awareness Month. And you get a free T-shirt during this month if you have a colorectal screening. So how about that for you for an incentive to come in and have it done? So, all right. Hey, Dr. Monte, as always, thank you for your time. Appreciate it. And for everyone, I thank you for taking the time to watch us and share this with your friends. Thanks.